Hi, guys. And we are going to go over chapter 43, which is pathology of the uterus. Um, this chapter is pretty long, has a lot of interesting things in it and a lot of detailed pathology. So I thought that we would split this chapter into 2 weeks. So today we're going to go over more of pathology of the uterus, and then next week we'll do more pathology of the endometrium. So let's get started. Pathology of the vagina and cervix. As we've talked about the last couple of weeks, the vagina runs anterior and caudal from the cervix between the bladder and the rectum. It's about 9 centimeters long, so it's pretty long. Um, Not too much can really go wrong with the vagina. There is very small chance of a possible tumor cancer, but it's very, very rare. What you might be able to visualize, or what a doctor would on a pelvic exam see if a patient felt something in the vagina, would be a Gartner's duct cyst. And again, that can cause a lot of pain. Here's the vagina here, and it's just next to the bladder, the urethra, and the rectum. So just straight in the middle, connected to the cervix and the uterus. So, like we were saying before, one of the most common congenital abnormalities of the female genital tract is the imperforate hymen, and this results in obstruction. What that means is when a lady starts her periods, and if she has an imperforate hymen, it does not allow for the blood to travel out correctly during the menstrual cycle. And so that it becomes an accumulation of fluid, blood, and pus in the uterus and vagina, and that can be very painful. So it's like they're having all of the symptoms of a period, yet nothing is happening, nothing's coming out. With imperforate hymen, they have to have surgery to correct that. Solid masses are rare, like we said, but there could be a potential carcinoma of the vagina, but it's very, very rare. And sonography doesn't really help in diagnosing that. And when we are scanning transvaginally, honestly, it's hard to see the full length of the vagina. Sometimes transabdominally it's better because you can kind of see the full length. But again, I think most things are diagnosed on a pelvic exam with the vagina. So what I mean by the vaginal cuff is if a patient has a hysterectomy, most of the time now what they do is they take out the cervix and the uterus and some of the vagina, and what is left is the vaginal cuff. Um, and you want it about 2.1 centimeters. If it's larger or contains a well-defined mass, that could be a suspicion for malignancy, especially in a patient that has a history of endometrial cancer or uterine cancer. So you know what a transvaginal ultrasound of a uterus looks like. So when a patient has a hysterectomy, they take out the uterus, they take out the cervix, they leave some of the vagina, and this is what you're going to see, just a little cuff, and this is the vagina. And that's how it appears on a transvaginal ultrasound. So if it's too large, that could be a indicator of some kind of malignancy. We've talked about the rectouterine recess, the posterior cul-de-sac, a couple of times, and we've also mentioned multiple times that there could be a potential accumulation of fluid during parts of the menstrual cycle, especially the ovulation, and maybe right around where the period starts. And that's normal to have a little bit of fluid. I need you to know what the rectouterine recess is and where it's located. And it's between the rectum and the vagina, and it's also called the pouch of Douglas, and frequent site for intraperitoneal fluid collections. And this is kind of what I just talked about. Most of the time it's just asymptomatic and it's seen during all phases of menstrual cycle. I see it more during ovulation. But if there's a large amount of fluid, um, it could be associated with ascites, which is accumulation of fluid within the whole, other regions of the body. Um, Blood resulting from a ruptured ectopic pregnancy, you're going to see quite a bit of fluid with that. If a patient has a hemorrhagic cyst or pus from an infection, you'll see quite a lot of bit of more fluid, and that usually likes to accumulate there and the right and left adnexa. So this is the uterus right here, and you can see that there's fluid in the posterior cul-de-sac, and then you actually can see that there's a little bit of fluid anterior to the uterus here. And I still feel like this is probably a normal amount, but I would mention it on my report that there's a mild amount of free fluid. Massive accumulations, and when I'm talking about massive, it's hard to miss. Like this whole area that's hypoechoic would be filled with fluid. It can occur in some ovarian carcinomas, again, ectopic pregnancy, appendicitis, rupture of a tubal pregnancy. That's when you get a lot of accumulation of fluid. Okay, so the cervix, it lies posterior to the bladder between the lower uterine segment and the vagina. And we've talked about the cervix a little bit. The anatomy of the cervix, extends from the internal os, and that's the part of the cervix that joins with the uterine cavity, to the external os, which projects to the vaginal vault. It's about 2 to 4 centimeters in length. And you can see it pretty well on transvaginal ultrasound. I always like to evaluate the cervix. So with a transvaginal endovaginal probe, when you insert the probe all the way, you're seeing more of the uterus. So to evaluate the cervix, you need to pull the probe out just a little bit, and that'll give you a better view of the cervix. And I like to do that before the exam is over. So I usually evaluate the uterus, and then I'll pull back just a little bit and just look at the cervical os, make sure I'm not missing anything. And it's a really good view. So this is the cervix here. This is the body of the uterus coming out here, and we can't quite see the whole fundus of the uterus because I'm sure on this ultrasound, the sonographer has pulled back the probe a little bit just to evaluate the cervix. And this is what a nice looking cervix looks like. You can see this line. This is the cervical canal. This is probably the internal os right here and the external os. But this is just a really good picture. And you evaluate the myometrium of the cervix, just make sure it looks good. There's no masses or anything. Now, we've talked about Nabothian cysts, and I know some people have had questions about that. And there are benign cysts that are in the cervix called retention cysts. Most of the time, they're asymptomatic unless they do get very large. They could rupture, cause some vaginal discharge, a little bit of bleeding, but that's pretty rare. What you're really going to see, and especially a lot of patients that have had babies, they seem to become more common, but you're going to see these circular little black areas within the cervix, and those are Nabothian cysts. Now, I usually, if I see multiple Nabothian cysts like this, I usually just mention it in my report, although nothing will be done about it. Some patients do present with irregular bleeding, and in that case, there could be a potential for a cervical polyp. Cervical polyps are very difficult to evaluate on ultrasound. That would be something that is better evaluated during a pelvic exam. The polyps can be pedunculated, project out of the cervix, or broad-based. And again, ultrasound is not great at seeing cervical polyps. Late to middle age are more likely to develop them. So if they're having bleeding, everything else looks good within the uterus, that could be a potential of why they're having abnormal bleeding. There is a small percentage of leiomyomas, or the fibroids that we'll be talking about, that occur in the cervix. When the myomas are small, patients are usually asymptomatic, but if they are large, they can cause some issues. Bladder or bowel obstructions can result. So I feel like a cervical fibroid is something that needs to be evaluated for. And I'll show you what that looks like in just a second. Okay, so this is the cervix right here. And then you see this large mass area within the cervix, and this is a cervical fibroid. Cervical myoma is the other word for it. The other thing that can happen with the cervix is cervical stenosis, and this is where the cervix narrows and blood fluid can't be released through the cervix as much as it should. This occurs like if a patient has radiation therapy, previous cone biopsy or LEEP procedure, postmenopausal cervical atrophy, chronic infection, or cervical carcinoma. And in that case, you're going to see fluid within the cervical canal and endometrial canal. Menopausal patients may be asymptomatic, even though the stenosis can produce a distended fluid-filled uterus. Premenopausal patients, so this happens to a patient that does have periods still, can have abnormal bleeding. Their periods cannot be like they should. They can just not be having periods because the blood can't get through. The cervix, cramping, painful issues, or even infertility. So this is what it would look like. You remember, this is our cervix, this is the body of the uterus, and this is the fundus of the uterus. This is the endometrial and cervical canal. And you can see this black anechoic fluid that has gone through the entire uterus and cervix, and this would be a case of cervical stenosis. Now, cervical cancer is actually not rare. It's actually one of those things that we need to take very seriously, and why pap smears are so important, and going to your OBGYN is so important. Squamous cell carcinoma is the most common type of cervical cancer, and precursors are cervical dysplasias, mild, moderate, and severe. Now, when you have cervical dysplasia that happens before the invasive or the pseudocarcinoma, they can do cone biopsy, LEEP procedures to remove those cells. The detection of these abnormalities is attributed to screening with a pap smear, because most early lesions are asymptomatic. And that's the scary part, is usually with cervical cancer, it doesn't produce symptoms until it's pretty advanced. This is a picture of cancer. This is a picture of it on ultrasound. Now you can see this undefined, ugly, hypoechoic area within the cervix. This patient's probably having heavy bleeding, pain. This is an advanced carcinoma. And then look how it lights up on Doppler and how vascular it is. This is a telltale sign that this patient has a cervical carcinoma, but by this time, it's pretty advanced stages and it's probably metastasized. So the other thing is cervical cancer affects women of menstrual age. So we're seeing like 20s to 40s. So it kind of hits pretty close to home, because it's something that could be friends and you in general could be at risk for this. Um, Clinically, you're going to present with vaginal discharge and excessive bleeding. Sonographically, if it is advanced stages, retrovesical mass, obstruction of ureters, invasion of bladder, it's pretty horrible. And our book that we're going to be reading later on in the semester is about a patient that had cervical cancer. It's such a great book. But just also very sad at what she had to go through. So some cervical cancer quick facts is it is the most common cancer affecting women. There's so many, HPV is a virus that is a risk factor for that. So patients that have HPV have a higher chance of having cervical cancer. But a regular pap smear can decrease the woman's chances of developing cervical cancer by 5 times. So just getting your regular pap smears could potentially save you from having the cancer, just because they can detect the cells that are starting to look like some cervical dysplasia and take care of it. High number of pregnancies increases risk. Women who smoke are 2 times more at risk. Usage of contraceptive is a factor of cervical cancer. And that's pretty much early sexual experience increases the risk of cervical cancer. So those are some of the risk factors. So now we're going to go to the pathology of the uterus. And like we said before, the uterus lies between the urinary bladder and the colon. The uterine position is variable, like we've talked about. It could be anteverted, it could be retroverted, it could be to the right side, it could be the left side. All right, I need you to know these, because these seem to be always on your test and they can be kind of confusing. So you remember that most of the time I just refer to it's either an anteverted uterus or a retroverted uterus, but technically you can have anteflexion, anteverted, and the difference is flexion refers to the axis of the uterine body related to the cervix. So it's going to curl more up. While version refers to the axis of the cervix related to the vagina. The uterus is usually anteverted and anteflexed, but it could be potentially retroflexed and retroverted. And that's why transvaginal ultrasound is such a good study for those patients that have those uteruses that flip backwards. Here's our uterine positions again. So anteversion, there's the vagina, and here's the body of the uterus here in cervix. Anteflexion is more of the cervix relation to the body. So it's like curled up. Retroflexion, same thing. The body of the uterus curls back. While retroversion is more the vagina to this cervix, it just is flipped back. But what I usually see is retroversion with retroflexion or anteversion with anteflexion. Okay, guys, anteverted or retroverted, what do you guys think? The fundus of the uterus is on the left side of the screen. The cervix is on the right side. Give you a second. This is anteverted. See the difference? Now the fundus is on the right side of the screen and the cervix is on the left side of the screen. This is retroverted. These are both transvaginal ultrasounds. And this is exactly what I said. Now, there are normal variations of the uterus, bicornuate or didelphic. Bicornuate is where you're going to have two horns of the uterus, and didelphic is going to be where there's actually could be two uteruses. I'm going to do another PowerPoint where I'm going to talk about Mullerian defects, which is these variations, and they don't really go too much into it in your book in this chapter, but I feel like it's so important. So stay tuned for that. Here are the different Mullerian defects, but again, I will talk about that in more detail on the other PowerPoint. This is what a bicornuate uterus looks like, though. You have your cervical canal, endometrial canal, and then it splits to like that heart-shaped uterus. Now, one of the indications for why you might do an ultrasound is an enlarged uterus. So patient goes in for a pelvic exam and the doctor's like, well, everything looks good, but your uterus appears a little enlarged. Let's get an ultrasound and make sure everything looks good. So these are reasons why enlarged uterus can happen. Pregnancy, a patient postpartum, which means just had a baby, the uterus is going to be larger. Leiomyoma, which is a fibroid, those benign tumors. Adenomyosis, which is when the endometrial tissue goes into the myometrium. If a patient has a bicornuate or didelphic uterus, carcinoma, or a uterine tumor. So you need to know those for your test. So thickened endometrium. Let's say you start scanning and you see that the endometrium looks thick. And what defines a thickened endometrium is greater than 1.5 centimeters. These could be the reasons why that could happen. Early intrauterine pregnancy. So before we can see a gestational sac or yolk sac, the patient has a thickened endometrium. And endometrial hypoplasia, which is just overgrowth of the endometrial tissue. Retained products of conception, or if a patient's had a miscarriage and all of the products did not come out, the endometrium can be thickened. Trophoblastic disease, which we'll talk about later on in the semester. Endometriitis, which is inflammation of the endometrium. Adhesions, if a patient has an endometrial polyp, inflammatory disease, or endometrial carcinoma. Now, let's say you're scanning and the endometrium isn't very thick, but there is some fluid within it. It could be a potential for endometriitis. So again, inflammation of the endometrium, retained products of conception, if a patient has pelvic inflammatory disease, or cervical obstruction. If you see some shadowing within the endometrium, this could be gas or which sometimes happens after pregnancy. I feel like there's some gas that accumulates within the endometrium. So sometimes you will see a little bit of shadowing. If a patient has a IUD for contraception, if there is a myomyoma or a calcified vessel, or retained products of conception. Now, the big takeaway that I want you to come from this chapter is one thing that you're going to see all the time, and they're called leiomyomas, and they drive me insane because they're so common and they're just make everything a little bit more difficult. And they're the slang term is fibroids, and that's how I usually define them. So they're the most common gynecological tumor occurring in approximately 20 to 30% of women over age 30. So they're very common, and they're more common in African American women. Myoma tumor is composed of spindle-shaped, smooth muscle arranged in whorl-like patterns. There could be some fibrous connective tissue. They just look nasty. That's what it looks like after post-procedure, surgical post-procedure. These are the nasty fibroids. Gross, but that's what they look like. So here's the characteristics of leiomyoma. So you need to know these. Their most common pelvic tumor. They're smooth muscle cell composition. Sometimes they degenerate and they outgrow their blood supply and they become calcified. They may be pedunculated, and clinically they can cause an enlarged uterus, profuse prolonged bleeding, especially during the menstrual cycle, and pain. Another thing that you need to know for your test is, and also just your general life, because you're going to be defining these all the time when you get out of school, are the different areas where you can have a fibroid. Subserosal is going to be right on the edge, you know, that serosa, which is the outer layer of the uterus. So a subserosal and fibroid is going to be right on the edge of the uterus there. Intramural, which are seem to be the most common, they're going to be in the myometrium, and most of the time, if they're not too big, they don't cause too much issues. Where the issues with bleeding and pain and everything come from are these submucosal fibroids, pedunculated fibroids, intracavital fibroids that press on the tissue and the lining of the endometrial cavity. And when that happens and it displaces the endometrial cavity or it bleeds through the endometrial cavity, that's when patients complain of menorrhagia, which is very heavy bleeding and pain. The uterine locations of leiomyomas are very important. So you have a submucosal, which is the disruption of the endometrial cavity, and that can cause heavy bleeding, infertility. Intramural, if they're very large, they can cause issues. If they're not, they usually, people don't even know they have them. But if they are really large or there's multiple, they can cause recurrent pregnancy loss or infertility. And subserosal arise from the myometrium project exophytically and may enlarge to cause pressure on adjacent organs. You can also have pedunculated fibroids that are coming off the uterus here. And that's another one I want you to know. So myomas are estrogen dependent. They go away. Most of them get smaller during menopause, but during pregnancy they can increase in size because the mom is getting fed all that estrogen throughout the pregnancy. But they rarely develop in postmenopausal women, and most are stables or decrease in size. The only time that they would really increase in size in a postmenopausal lady is if there could be a potential that it's a neoplasm instead of a fibroid, and those are called leiomyosarcomas. So they're the cancerous form of a leiomyoma. Clinically, myomas cause uterine irregularity and enlargement with pelvic pressure and sometimes pain, patterns of irregular bleeding, heavy menstrual periods are the main clinical problems. And if there is a fibroid within the cavity, it can cause infertility. So same thing again, this is what we're kind of talking about. If they are pedunculated, they can appear as extrauterine masses, and you want to make sure that you're distinguishing them, fibroids, from the ovary, because sometimes they can look like they could be, the stalk could be the fallopian tube or the ligament, and then the mass or the fibroid could look like the ovary, but it's not the same texture. Here's one more good picture of the intramural. This is a pedunculated fibroid. This can cause some issues with other organs or pain. Subserosal, submucosal, intracavitary. Submucosal myomas may erode into the endometrial cavity and cause irregular bleeding and heavy bleeding. And that's when you get the patients that have just horrible periods and are just complaining of menorrhagia, can't do anything, or having clots and bleeding. A lot of the times you're going to find a fibroid or something going on within the endometrium. So this is the uterus. This is a transverse ultrasound. So you can see that we're kind of cutting it in half, looking kind of down at the uterus. And this is the endometrial cavity in transverse. And then you can see there's this circular mass within the endometrial cavity. And this would be, I believe, a submucosal fibroid. And that would probably give the patient would probably have clinical symptoms. This is more of an intramural, but you can see it kind of is like, and it's not, they're never really greatly defined. They're more ill-defined. They're kind of, and you know, our little students, they kind of struggle at first finding these fibroids, and they get concerned. And honestly, to be honest, sometimes I'm like, I still don't know if it's a fibroid or not. It looks like ill-defined. It's hard to see the borders. You know, it looks like there could be potentially something there. So they're difficult to see. They're not just going to stick out a lot of the times. Here's another. This is a sagittal ultrasound. This is the cervix. This is the fundus. This is the antiverted uterus. This is the endometrial cavity, and then there is a mass within the endometrial cavity there. It's the mucosal. These are intramural fibroids. You can see they look like nasty little masses. This is a 3D ultrasound. So this is if you're cutting, it's like more of a coronal view where you're cutting the uterus in half and you're looking into it. This is the endometrial canal, and then you can see inside the endometrial canal, you can see this little mass here, and that would be like an intracavitary or submucosal fibroid. Look at this nasty fibroid. That whole thing is like a fibroid. More intramural, I would say. So what do people do? Well, if a patient is having infertility, you can actually get a myomectomy and have the fibroids removed. In some cases, if a patient is done having babies and they have multiple fibroids that are giving them tons of problem, a lot of the times they could do a hysterectomy. But if a patient is not wanting a hysterectomy, the least invasive procedure would be hormone suppression to stop the bleeding, because they feed on estrogen, and the oral contraceptives can kind of help suppress that. There's endometrial ablation you can do. There's some other, an embolization, high focused ultrasound, but a lot of the times I either see, you know, patient put on OCPs, myomectomy, or hysterectomy, depending on where a patient is in life. Myomas are the most common cause of uterine calcifications, and the reason is like they lose their blood supply and then they kind of calcify. You can also have calcifications on the edge of the uterus, and I see this a lot in postmenopausal ladies. And it's called arcuate artery calcification. And it's usually, you know, there's no reason, it's just because the body's getting older and the arteries start to calcify. And I think that's all I want you to know with that. Okay, so this is a postmenopausal uterus. You can see it's a lot smaller. And you can see these little echogenic areas on the edge, the periphery of the uterus. And these are just arcuate artery calcifications. Now, adenomyosis is the last thing I think we're going to talk about today. And it's a benign disease, diffuse or focal, but it can cause some serious issues for patients. It's global infiltration of the endometrium. So the endometrial tissue goes into the myometrium, causing lots of pains. The graphic appearance is a bulky enlarged uterus without a focal mass, so the uterus just looks very heterogeneous. You could get some shadowing and acoustic enhancement. We call this Venetian blinds, which is another like kind of ultrasound sign for adenomyosis. Mostly adenomyosis occurs in the posterior aspect of the uterus. And focal adenomyosis is called adenomyoma. And it's usually when there's just isolated implants of the endometrium within the uterus. But most of the time you're going to see just a a very enlarged uterus that's bulky. It has acoustic enhancement. It just doesn't look good. And then the patient's going to have the clinical symptoms of adenomyosis. So these are the clinical symptoms: hypermenorrhea, abnormal uterine bleeding, prolonged profuse uterine bleeding, which is menorrhagia, and metrorrhea, which is irregular acyclic bleeding. Some patients are going to have dysmenorrhea or pelvic pain with it. So these are the common presentations: diffuse uterine enlargement, thickening of the posterior myometrium, indistinct border of the endometrium and myometrial cysts, so little cystic areas within the myometrium. So, and this is what I'm talking about with Venetian blinds. There's just like, you can see there's just some posterior acoustic enhancement, then some shadowing, posterior acoustic enhancement, then some shadowing. And that's a good sign for me that there's something going on in the posterior myometrium. I don't know why that happened, but I'm sorry about that. Hemorrhage in, let's see here. Yeah, you can have myometrial cysts, and you can't see them very much here, but they're going to be like little cystic areas within the myometrium. There's some right there. That's another thing that kind of points you in the direction of adenomyosis. And also you can have some calcifications that form. Look at this Venetian blinds. All right, so here's the anterior uterus. This is the posterior. Look how bulky it is. It's heterogeneous. There's no distinct mass, but it just doesn't look like pretty, you know? And then on top of that, you have these acoustic enhancement, like these, that is just kind of shadowing throughout the uterus. And then you have your myometrial cyst. This would be a case of adenomyosis. I'm sure the patient was presenting clinically too. Now, a uterine leiomyosarcoma is the rare solid tumor that arises from the myometrium or endometrium. And it's commonly in the fundus of the uterus, and it's most common in 40 to 60 years of age and has rapid growth. Now, it appears as a fibroid. So usually when you see a fibroid, or a patient does a pelvic, or a doctor does a pelvic exam, says, I think I feel something, we go in, it looks like a fibroid. What he'll do is he'll order a 3-month follow-up. That's what they look like. 3-month follow-up to reevaluate the fibroid. They don't want it to get too big too fast. If it gets too big too fast, especially in 40 to 60-year-olds, it could be a potential that this is not just a benign leiomyoma, but yet a leiomyosarcoma, because they grow at such a fast rate. So that's why they want to follow up on these fibroids. So clinically, rapid enlargement of solid uterine mass in perimenopausal, postmenopausal patient raises concern about development of malignancy. All right, guys, that's it for today on this one. We'll go over the rest next week. No test next week. All right, thanks. Have a good week. Bye.